Good morning, sir. Good morning,
Good morning, Asif. Good
uh,
morning. We look
yes,
forward to this talk.
yes. I think we'll start with this.
Yes,
Today we presenting the spaces, and
yes.
then we may show a couple of more cases possible.
Okay,
And
okay. Thank you.
you prepared a talk, and Manthan is starting with the talks.
Y- Yes, please. I'm looking
Yes,
forward to it.
thank you, sir.
Thank you.
Very good morning, everyone. Today we will be discussing about the next phases. So in this talk, we will be discussing under the following heads. We will go through the anatomy and anatomy of the neck and its various divisions by the different facial layers. We will look into each and every individual spaces with their normal contents and few of these pathologies and their relation with the adjacent spaces. So if you look at the facial layers, we have the superficial and the deep facial layer. And further, the deep layer can be divided into superficial part, which is also known as the investing layer, the middle part, which is known as the visceral layer, and the deep part of the deep fascia, deep cervical fascia, which is known as the prevertebral fascia. So all these fascia, they are all vertical, and they are not they are aligned vertically and not horizontally. Hence, no vertical separation can be made by these fascia, and all the non SCC lesions will be seen confined in their respective fascia. They won't extend across the fascia, unlike an SCC lesion, which won't respect these fascia and it's tends to extend across these fascia. So just a diagram to just show how these the various facial layers are aligned, are vertically aligned, and one of these, this marked D, is the alar fascia, which we will be seeing discussing about it in the coming slides. So this alar fascia is one of the fascia which divides the retroperitoneal space into retroperitoneal space anteriorly and danger space posteriorly, and we can see that this danger space extends inferiorly and communicates inferiorly with the mediastinum. So just orientation about the vertical how these fascias are aligned vertically. So before starting the next piece is just regarding the evaluation of a patient presenting with a neck mass or neck swelling. Beginning with the clinical examination, depending on the location of the lesion in the oral cavity, any intraoral examination, thorough examination, any laryngeal lesion, any FOL, etc. And followed by imaging of the neck masses, mainly would comprise cross-sectional imaging, CT scan and MRI. Ultrasound will definitely help in some of the cases uh, where we can also look at the exact composition of the lesion and its relation with the adjacent structures. And lastly, we have X-rays and the OPGs depending on the particular disease. So whenever we encounter a neck mass, we can systematically we can approach it in a systematic manner. Firstly, on imaging, we always need to make sure that we have aligned the scan symmetrically, irrespective of the plane in which the scan has been acquired. We need to make it symmetrical, and then so that we can then compare the normal with the abnormal side. So whenever we see the lesion, first we need to recognize that which space does the epicenter of the mass lie in. So if after the, on this step we identify the particular space. So next step would be what are the normal contents of this space, and based on the contents of this space, we can have the various pathologies related to that, which we can further we can narrow down based on imaging pattern and the relevant clinical history. So if we try to follow this approach in each neck spaces, we can definitely narrow down to the closest couple of differential diagnosis for that particular pathology. So the neck spaces, they are divided into suprahyoid and infrahyoid neck. So that's the hyoid bone. And this is a sagittal CT section. This yellow line marks the level of the hyoid bone. So superior to that, we have all the suprahyoid neck spaces, which extend superiorly up to the base of the skull. And inferior to the hyoid, we have the infrahyoid spaces, which extend up to the thoracic inlet. So just to list the various spaces in the suprahyoid neck, we can divide the spaces, those located medially and those located laterally. So in the median spaces, we have the pharyngeal mucosal space, the retropharyngeal space, and the perivertebral space. And lateral spaces in the suprahyoid neck include the masticator space, the parotid space, buccal space, parapharyngeal space, carotid space, and the posterior cervical space. After looking at the suprahyoid neck spaces, this slide highlights those spaces which span across both the compartments, that is suprahyoid as well as infrahyoid neck. So, medially, the retropharyngeal space and the perivertebral space, they are located in both in the suprahyoid as well as in the infrahyoid neck. And laterally, we have the carotid space and the posterior cervical space, which are located both in the supra and the infrahyoid neck spaces. So we are totally in four spaces which are span across both the compartments. And in the infrahyoid neck, in addition to the four spaces which we saw in the last slide, we additionally have the visceral space medially. So totally we have these 5 spaces in the infrahyoid neck. So starting with the suprahyoid neck spaces, we start with the masticator space. So this in this diagram, this is a masticator space located laterally, and the contents of this space include our muscles of mastication, that is the masseter muscle, temporalis, the lateral and the medial pterygoid muscles. In addition to that, we have the nerve, which that is the mandibular division of the trigeminal nerve. So that, and also it runs mainly the inferior alveolar nerve, which runs in the mandibular notch, the mandibular canal. And lastly, the bony component of this space is the posterior body of the ramus, posterior body and ramus of the mandible. So to sum up, we have the contents. We can divide the contents of the masticator space into one muscle, second bone, and third nerve. So any pathology in this space, we can just will be related to these. So we can have either a muscular pathology, and a neural origin of the pathology, or any bony pathology. So this masticator space is the largest space of the suprahyoid neck, and to show these are the coronal, the coronal diagram, and followed by a coronal CT image to show to show the extent of the masticator space, because it is very important to note its extent in the suprazygomatic portion, which comprises of the temporalis muscle. So we can see this is the zygomatic arch, and we have infrazygomatic and suprazygomatic portion of the masticator space. So it's always, so this slide was just to highlight in this slide that the superior extent of the masticator space needs to be kept in mind, because it's quite a large space. Just to show a few pathologies of the masticator space. So we have this is the axial T2 weighted MR image and a coronal T1 contrast MR image. We can see a solid cystic mass lesion out here, which is adjacent to the Meckel's cave in this diagram. And in the coronal contrast image, we can see this lesion, and heterogeneity enhancing lesion. This is the portion. This portion of the lesion is adjacent to the Meckel's cave and the cavernous sinus, and if you can see it communicating, like you can inferiorly, you can see it's extending across this. This is the foramen ovale, so which is expanded, and we can see the lesion spanning across it. And inferiorly, we can see the lesion is extending in the masticator space. So this is the entire extent of the lesion, the masticator space extending across the foramen ovale up to the level of the cavernous sinus. In addition to that, we can also these curved arrowheads denote the atrophy of the masseter and the pterygoid muscles, because since the nerve, since this lesion is involving the nerve, there is atrophy, secondary atrophy of these muscles. So this is a case of mandibular nerve schwannoma, and we can see how the masticator space is we can how it extends superiorly, and how the lesion also originating in the masticator space is seen extending superiorly. Another pathology of the space, you can see this large lesion which showing a typical sunburst type of periosteal reaction with soft tissue, and so this is a pathology of the masticator space related to the bony element, and this is a typical case of mandibular osteosarcoma. So we have seen we have seen the contents of the space, that is muscle, bone, and nerve, and accordingly we have just discussed a couple of pathologies. Previous mandibular nerve schwannoma related to the nerve, and osteosarcoma related to the bony origin. Also, just to mention about a few of the pseudomasses in relation to the masticator space. So we can see here, this is a this MR image. This is a axial T1 weighted MR image. So this is the masseter muscle. This is the parotid gland on the right side. And if we look on the left side, this is a masseter muscle, and we can see that we have a process which is rising from the parotid gland, and it is seen extending anteriorly along the masseter muscle. So this is known as the facial process of the parotid gland. And so the significance is that if we have any pathology arising from this process, it may be mistaken for a masticator space pathology. However, its origin is in the parotid gland. So this is known as the facial process of parotid gland. And another condition we can see here, these soft tissue out here along the masseter muscle on the left, and also here on the right side. These are examples of accessory parotid gland tissue. We have the normal parotid glands here, and we have the accessory tissues out here anteriorly. And so again, the same. Yeah. If any pathology arising from this, their origin will be parotid, but they may be mistaken for masticator space pathology in going to the location of the that mass, if any arises. So that was about the masticator space. Now we look at the parotid space. This is in the suprahyoid neck. So this was the masticator space which we saw. Now posteriorly, this is the parotid space. And the contents of this space are the parotid gland, superficial, and the deep lobe. In the superficial and deep lobe, they are divided by the retromandibular vein. So we have the retromandibular vein in this space. We have the facial nerve, which lies lateral to the retromandibular vein. Then we have some branches of external carotid artery in this space. And lastly, we have lymph nodes. So based on these contents, we can have various pathologies related to the parotid gland, to any vascular cause. We can have lymph nodes. So we can, based on the contents, we can have corresponding pathologies. So just looking at one of the pathologies in the parotid space. So these are the axial MR images, T1 T2 and T1 post contrast image. We can see a lobulated SOL in the left parotid gland, which is involving the superficial as well as the deep lobe of the left parotid gland, and it is iso-intense on T1 weighted image. It's hyper-intense on T2, and it shows heterogeneous post contrast enhancement. So, looking at this, all these images, this is a typical case of pleomorphic adenoma involving the left parotid gland. So, yeah, this is one of the pathologies in the parotid space. Another pathology in this parotid space. So this is we have an axial CT, and on the right we have a coronal T2 fat sat image. So on the CT image, we can see the phleboliths which are in the hyperdense foci, the phleboliths, revealing phleboliths in the superficial lobe of the left parotid gland. And on the corresponding MR image, we have a heterogeneously hyperintense mass involving the parotid gland with the arrowheads showing the hypointense foci, which correspond to the phleboliths seen on the CT. So we all know that the phleboliths are like a hallmark of venous malformations. So this is a case of venous malformation of the left parotid gland. Uh, Lastly, we can have cystic lesions in the parotid, and the differentials for the cystic lesions in parotid include first branchial cleft cyst, lymphatic malformations, and abscess, and lastly lymphoepithelial cysts, which are usually seen in RVD patients, and also we can have bilateral lymphoepithelial cysts in an HIV patient. So this is ultrasound image in an HIV patient who had the cystic lesion in the parotid, showing a few internal lesions. So yeah, so these are cystic lesions of the parotid. Next, we move on to the buccal space. We are in the suprahead neck. We have seen the masticator space, the parotid space. Now we'll see the buccal space. So buccal space is located anteriorly. So this is the area of the buccal space, and it contains fat. It also has a comprises of the distal part of the parotid gland, wherein the parotid gland from behind it comes anteriorly along the masseter, and it pierces the buccinator and opens with the second molar tooth. So the distal part of the parotid duct is in this buccal space. You have the buccinator muscle, you have the facial artery and vein in this space, and also uh, we need to remember that this retroantral fat pad is also a component of the buccal space. So in addition to the fat and the parotid duct, buccinator muscle, and the facial artery veins, we also have the retroantral fat, a part of the buccal space, and this retroantral fat is also one of the components of infratemporal fossa. So just to mention about the other components of the infratemporal fossa, so this is the dotted lines. They denotes the infratemporal fossa. So components include anteriorly we have the retrantral fat, which is the part of the buccal space. And we have seen the masticator space. This is the masticator space. So if you look at the infratemporal fossa would comprise of the masticator space excluding the masseter muscle and the bone. So the masticator space minus the masseter and the mandible would be the component of infratemporal fossa. And also, we have a part of this fat space out here is the parapharyngeal space. We'll be discussing about it later. So this is a part of the parapharyngeal parapharyngeal space in the infratemporal fossa. So these three, retrantral fat, some portion of the masticator space, and this parapharyngeal space. These are the components of the ITF. Coming to the pathologies in this bucket space, since we can just correspond, like we can just go through the normal contents, and accordingly, we can have various pathologies, like from fat we can have a lipoma. Most commonly we encounter we have the SCCs of the buccal mucosa, wherein this very important to document the puff cheek maneuver, wherein the lesion stand out as compared to a normal scan. We can have vascular malformations, and lastly, we can have infections in this bucket space. So these are the various pathologies in this bucket space. Next space in the suprahead neck. So we have seen all this three spaces laterally. Now we come medially in the suprahead neck, and firstly we come to this pharyngeal mucosal space. You can see this is the pharyngeal mucosal space marked here. It comprises of the pharyngeal mucosa proper. We have the lymphoid ring, you know, the Walde's ring, and also it comprises of the minor salivary glands. So these are the contents of this pharyngeal mucosal space. Related to these norm contents, we can have their related pathologies. So let's have a look at a few of these pathologies. So in this axial CT image, we can see compare the right and the left side. You can see on the right the mucosa is obliterated, and you can see this soft tissue lesion. With the epicenter of this lesion is medial to the parapharyngeal fat. This is the parapharyngeal fat, and the epicenter of the lesion is medial to it. And this lesion is seen displacing this parapharyngeal fat laterally. This is the normal parapharyngeal fat space on the left side. So we can see this epicenter of the lesion in the nasopharynx. This is the eustachian tube opening. This is the torus tubarius. This is the fossa of Rosenmüller. So this is a typical case of nasopharyngeal CA. And this is one of the pathologies of the arising from the pharyngeal mucosal space. Another few MR images of nasopharyngeal CA. We have the axial T1 and axial T1 post contrast image. You can see, you can see this iso-intense lesion in the nasopharynx, which is showing heterogeneous post contrast enhancement. We saw the Walde's ring. So we can also commonly in this space we have this one of the adenoid hypertrophy, which we commonly see in this X-ray in the children as a soft tissue fullness in the nasopharyngeal region, causing the airway narrowing. So this is the adenoid hypertrophy on this X-ray, and corresponding sagittal CT image showing the adenoid hypertrophy. So that was about the pharyngeal mucosal space. Now we move on to the parapharyngeal space. So that was the pharyngeal mucosal space. Now lateral to it, we have the parapharyngeal space. This space comprises predominantly of fat. So, and apart in addition, we also have some few vessels and minor glands in this space. But predominantly it contains fat. And we have very few lesions which primarily originate in this space. Most commonly we encounter, extensions of pathologies from adjacent spaces into the parapharyngeal space, and various pathologies which can involve the parapharyngeal space include tumors originating from the deep lobe of parotid, or from the minor salivary glands, neuromas or glomus tumors. Also, we can have infections from adjacent spaces involving the parapharyngeal fat space. So, as we have seen, like there are very few primary lesions. We have very few primary in this lesion. Whenever a lesion primarily arises in the parapharyngeal space, we'll be able to appreciate fat all around that lesion, which will tell us that the lesion is originating in the parapharyngeal space and not extending from any lesion not extending from any space adjacent to it. And if we have, like in most cases, pathology extending from adjacent neck space, then the direction of fat displacement is the key to the localization of that suprahyoid neck mass. So, based on which space is involved, the parapharyngeal fat will be displaced accordingly, and that can give us a clue to the area of origin. So, these diagrams we can see the various displacement directions of displacement of the parapharyngeal space. So, in diagram A, we can see if we have a pharyngeal mucosal space, this is the area of PPS is the parapharyngeal space. So if we have a pharyngeal mucosal space lesion, we can it will displace the parapharyngeal space laterally, as we have seen in the previous case of nasopharyngeal CA. So that will be the direction of displacement. In diagram B, this MS tumor will be is a masticator space lesion. So in a masticator space lesion will displace the parapharyngeal space posterolaterally. We can just have a look at the location of the various spaces, and we can just accordingly see how it will displace the parapharyngeal space. This is a parotid space lesion, so which will displace the parapharyngeal space anteromedially. And in this diagram D, we can see CS would be a carotid space lesion. This is located posterior to the parapharyngeal space. So any lesion in this carotid space will displace the parapharyngeal fat space anteriorly. So it's all depending on the location of the spaces, and we can just see how if any tumor is originating in the space posterior to the parapharyngeal space, it will displace the space anteriorly. If any lesion is medially, then it will displace laterally. So so we can accordingly, based on the location of the displaced parapharyngeal fat, that can give us a clue about the epicenter of the lesion in the corresponding neck space. To have a look at the few of the pathologies involving the parapharyngeal space. This is a case of a lesion involving the deep lobe of parotid. So that's the parotid gland, superficial lobe, that's the deep lobe. And we can see that more than 50% of the lesion is surrounded by the parotid, and it's seen extending medially, and it's causing widening of the stylomandibular tunnel. So this is the styloid process, as the mandible. So this stylomandibular tunnel is widened. We can compare it on the left side, with normal on the left side, and this is widened. So this stylomandibular tunnel is the usual location of the deep lobe of the parotid. And in this pathology, in this case, where we have a mass lesion, we can see this tunnel to be widened, and also we can see that's the parapharyngeal fat, which is displaced anteromedially by this mass lesion. We can compare it with on the left side. That's the normal parapharyngeal space on the left side. Here, because of the mass, it is displaced anteromedially by the parotid space lesion. So we can see this is one of the examples to see the displacement of the parapharyngeal space in the case of parotid space lesion. Another example of a carotid space lesion. So this is a case of a typical case of a enhancing carotid body tumor causing splaying of the internal and external carotid artery. So we can see this black fat that's the parapharyngeal fat space, which is in this case displaced anteriorly by the carotid body tumor, because we have the carotid space posterior to the parapharyngeal space. So because of the tumor, the parapharyngeal space is displaced anteriorly. So that was about the parapharyngeal space. So the most important part of that is we need to always look at the direction of displacement of the fat, which will give us a clue to the epicenter of the lesion. Next, we move on to the retropharyngeal space. So the spaces till now we have seen they're all in the suprahyoid neck. Now we move to the spaces which span across both the compartments. One of the first we start with the retropharyngeal space medially. So that's the area of uh, retropharyngeal space. That was the pharyngeal mucosal space.
Hello? Can you
Yes,
show
sir.
us the carotid body tumor again
Yes,
and
sure.
show how it is pushing the space anteriorly? Is it in the post-styloid compartment
Yes, sir.
Yes,
as against the deep lobe parotid, which is in the pre-styloid?
Yes, sir.
yes.
So where
Sure.
is the styloid process in the carotid body tumor? Please point out. Which is the styloid process here?
That is, sir, only the lower part is
Lower
seen
portion.
because the lesion, the section is a little bit lower in the space wise.
Okay. All right.
That is,
Okay.
yes, sir.
Okay. I was
It
trying to
would come,
locate that.
yeah, it would come somewhere in these areas, here on the
Mhm.
medial sides.
We need to have this clarity about the pre-styloid and the post-styloid compartments, of the parapharyngeal space. That's why I
Yes, sir.
interrupted. I'm sorry. Sorry, I
No,
had to
no,
interrupt that.
it's a very important point. Yes, sir.
Yes, sir.
Mhm.
Yes, as Sir has also pointed out. So the carotid space would be a post-styloid parapharyngeal space, and the parapharyngeal space which we discussed, that's the pre-styloid parapharyngeal space.
So in the previous slide, show that again, styloid process, the one behind. Yes.
So this is the styloid process, and we yeah, this is styloid process, and this we had the parapharyngeal fat displayed anteriorly, located normally in the pre-styloid space. When by the mass, it is space anteriorly.
Yeah, that's the fact.
Yeah, this one.
Yes, that's the fact plane.
Thank you. Thank you.
Thank you.
Please continue. Please.
Yes. Yeah. So we had seen the spaces in the previously spaces in the suprahead neck. Now we move on to the spaces which span across both the compartments, supra as well as infrahead neck. Starting with the retropharyngeal space. So this area marked in the black, highlighted by the black, that's the area of the retropharyngeal space. The space that's the pharyngeal mucosal space, and posterior to it we have the retropharyngeal space out here. The space extends from the skull base to approximately T3 vertebral level, and as we know, it spans across both supra and as well as infrahead neck. The suprahead compartment, it comprises of fat and lymph nodes, and in the infrahead portion, it mainly comprises of fat. And we also have a thin alar fascia, which divides this retropharyngeal space into anterior and posterior compartment. Anterior compartment is the true retropharyngeal space, and posterior compartment is known as the danger space. Yeah. So in this diagram, we can see this thin this thin line. You can see that's the alar fascia. Anteriorly, we have the true retropharyngeal space, and posterior to it, we have the danger space. This so that's the danger space is the pusher compartment, and inferiorly, the space extends inferiorly up to the level of diaphragm, and because of its that inferior extent, It provides a direct pathway for spread of infection to the mediastinum. So that's why it's known as a danger space, as it is a pathway for the spread of infection and other pathology. Now in the SAG image, there's a that's the alar fascia, and posteriorly we have the danger space, and you can see how it is tracking inferiorly up to the mediastinum. So coming to the pathologies of the retropharyngeal space, so we saw mainly the contents of the space mainly comprising of fat and lymph nodes. So we can have adenitis, which is commonly seen in children following URTIs. We can have if there's a resultant separation of the in the nodes, then we can have an abscess. We can have lipomas, and also we can have a medialized carotid vessel, which which will be located in the retropharyngeal space. This should I this the sagittal CT and axial CT images. They show hypodense collection. This is a case of a retropharyngeal abscess. Also another case of we can see the axial CT and coronal CT images post contrast showing multiloculated collection which is epicentered in the retropharyngeal space, and in the coronal section we can see how it is seen extending along inferiorly and tracking up to the towards the mediastinum, as we have discussed. And so this is a case of a multiloculated retropharyngeal abscess. So that's mainly to highlight this image to highlight how any pathology can extend inferiorly and can be more critical. So that was about the retropharyngeal space. Next, we move on to the another space which spans across both the compartments. That's the perivertebral space. So we are just moving more posteriorly now. That was the area of the retropharyngeal space. Now we move posteriorly. This space, which is just highlighted by the pink color, that's the perivertebral space, and this space also extends from the skull base to the mediastinum, and it is divided into two portions by the transverse processes of the vertebrae. So that's the transverse process, and we have two portions. Anteriorly, we have the prevertebral component of the perivertebral space, and posterior to the transverse process, we have the paraspinal component of the perivertebral space. So those are the two components of the perivertebral space. And coming to its contents, we can have all the various the paraspinal muscles. We have the vertebral artery. We have all the nerve roots, and lastly we have the bony element, that's the spine. So related to all these pathologies, we can have their corresponding pathologies related to these contents. We can have a bony origin, any bony pathology. We can have a neural pathology, any muscular pathology, or any arterial cause. And just to like important points to remember in the perivertebral space involvement, two features of very peculiar to the space involvement would be vertebral distraction, and secondly lifting of the prevertebral muscles. So any vertebral distraction will definitely be epicentered in the perivertebral space, and secondly any pathology out here which will cause the lifting of the prevertebral muscles. So that will give us a clue that the epicenter of the lesion is in this perivertebral space. So yeah, just a slide to just show the various pathologies which we can have. So what we come these are the contents of the space and corresponding pathologies which we can have. So bony pathologies, we can have osteomyelitis, bone tumors, we can have mets, we can have various muscular pathologies, neural pathologies. We can have schwannoma, neurofibromas, And lastly, related to the vascular, the vertebral artery vein, we can have their corresponding pathologies like aneurysm, dissection, or thrombosis. Yeah, so this image shows one of the pathologies of the perivertebral space. So these are the axial and sagittal T1 post-contrast MR images. So we can see in this image there is vertebral destruction in this region. We have vertebral destruction with corresponding prevertebral soft tissue and paravertebral peripherally enhancing collections. So these are the paravertebral abscesses with vertebral destruction, and this is a typical case of pot spine. So this pot spine is one of the pathologies of the perivertebral space. Another pathology of the perivertebral space. These are the axial T2 fat sat MR images and axial T1 post contrast images. So we can see a heterogeneous hyperintense solid cystic lesion in this region. We can see it's originating arising from the neural foramen, and on the post contrast images it shows heterogeneous enhancement. We can see the enhancement of the solid component and the non-enhancing cystic component. So solid cystic mass arising from the neural foramen. This is a case of brachial plexus schwannoma, and and this is one of the pathology which can arise in the perivertebral space. That was about the perivertebral space. Now we move on to the third space spanning across both the both the supra and as well as the infrahyoid neck, and that is the carotid space. So now we move a bit laterally from the retropharyngeal and the perivertebral space laterally. So carotid space, as we have discussed, this carotid space is located posterior to the styloid and also known as the post-styloid parapharyngeal space. And this space extends from the skull base to the aortic arch. So this space is a vertical highway which is flimsy in the suprahyoid compartment and it's more complete in the infrahyoid portion. That's yeah, this is axial CT image. That's the carotid space with the carotid vessels. So the contents of the carotid space include the carotid arteries, the internal jugular vein, and we have the 9 to cranial nerves 9, 10, 11, 12 in this space. The cranial nerve 10 vagus nerve is located all along the carotid space in the suprahyoid as well as in the infrahyoid portion. Whereas nerves 9, 11, and 12, they are only located in the suprahyoid portion of this space, and they are not present in the infrahyoid portion of this nerve because they leave at the soft part level to their respective locations. So we only have cranial nerve 10, which is located in both in the supra as well as the infrahyoid portion. In addition to that, we have the sympathetic chain and lymph nodes. So these are the components of the carotid space, and correspondingly, we can have their various pathologies. So related to the artery, we can have aneurysms, thrombosis, dissection. Likewise, in jugular vein related, we can have thrombosis, thrombophlebitis. We can have neural tumors, schwannomas, neurofibromas. We can have paragangliomas, and also we can have lymphoma mets, and also we can have second branchial cleft cyst in this location. So these are the various pathologies which can arise in the carotid space. So just a few diagrams to show how various carotid sheath pathologies have, have different relations with the arteries and the jugular vein. So this yellow portion is you consider this yellow circle as the mass arising in the carotid sheath. These red dots as the internal and the external carotid arteries, and the blue one as the internal jugular vein. So, in case of a carotid body tumor, the mass lesion will cause splaying of the internal and the external carotid arteries. Whereas in a vagal schwannoma, we can see this mass lesion would displace the carotid arteries anteriorly and the jugular vein posteriorly. So that will be the different this relation will be different in case of a carotid body tumor. And also in this any sympathetic chain mass, we can see how the jugular vein and the carotid arteries are aligned in this manner. So based on how these vessels are displaced, that can give us a clue about the origin of the tumor. There's a few ultrasound images. In this case, we can see this M denotes the mass lesion which is seen in the carotid sheath. And you can see it's seen displacing the IJV and CCA on the either side. And this is points out, as we have seen in the diagram, this is vagal nerve origin, a vagal nerve tumor, versus a carotid body tumor, where you can see it is this lesion is causing splaying of the internal and the external carotid arteries. So just to mention about the differentiating points were in the neurogenic tumor versus a carotid body tumor. Look, the vascularity will be more intense in a carotid body tumor. The neurogenic tumor would be fusiform or oval with a long axis parallel to the vessels and extending more inferior to the bulb. Carotid body tumor will be lobulated and focal, extending more capillary. We have seen in the previous slide that the vascular displacement the carotid body tumor will cause playing of the carotid arteries, and the neurogenic tumor will displace the carotid arteries and the jugular vein on the other side. Also, in case of a neurogenic tumor, entry of the exit nerve may be seen as a tail sign, and in case of carotid body tumor, adjacent large arterial feeders from the ECA branches may be seen, and an angiography would be diagnostic for that. So, so this is a typical case of a carotid body tumor. We can see the intensely enhancing lesion causing splaying of the external and the internal carotid artery. And we are also seen while discussing the parapharyngeal space that this tumor displaces the parapharyngeal space anteriorly, and corresponding sagittal image where we can see the splaying of the internal and external carotid artery known as the Lyle's tumor. Few other images. This patient had a bilateral neck swelling, and on examination also there were pulsations were felt over the swelling on either side. So this on the ultrasound image, you can see this intensely enhancing mass, and corresponding ultrasound image on the right side, you can see how it's causing splaying of the carotid arteries. And so this is a case of bilateral. This is a case of bilateral paragangliomas. You can see the displaying of the vessels in these diagrams. Another ultrasound image of this mass lesion, which is seen pushing the carotid arteries anteriorly, unlike what we saw in the previous carotid body tumor, where it was causing splaying. And this is a case of a carotid sheath neurogenic tumor. You can see that the vessel relation is different. The carotid artery is seen pushed anteriorly. This is corresponding PET CT image. That's the lesion. Another coronal and axial CT post contrast images. You can see this lesion which is, and that's laterally, that's the jugular vein, that's the carotid artery, and corresponding axial sections, that's the lesion. That's the laterally, that's a jugular vein, and that these are the carotid arteries medially. So this is a case of vagal Schwann. So that was about the carotid sheath tumors and how they have different relations with the vessels. And another case of the carotid sheath, this is ultrasound image showing a cystic lesion uh, between the sternocleidomastoid and the carotid vessels, and corresponding axial CT post contrast images. We can see non-enhancing the cystic lesion. We can also see, so we can see this black portion, this hypodense, that's the parapharyngeal parapharyngeal fat, which is displaced anteriorly and medially. And this image we can see this is the cystic lesion, and we can see how the carotid arteries and the jugular vein, they are all displaced located medial to the cystic lesion. And cystic lesion in the carotid space is a uh, case of a second branchial cleft cyst, one of the another pathologies of the can arise in the carotid space. That was about the carotid space. Now we move on to the fourth and the last space, which spans across both both across both the supra and the infrahead neck. That's the posterior cervical space. So this is this area, this region. This is the area of the posterior cervical space on either side. This space extends from the mastoid to the clavicle level. It contains fat, contains the spinal accessory and the dorsal scapular nerves, and also it contains lymph nodes. So these are the the contents, and we can have corresponding pathologies related to them. So as far as concerned, we can have lipoma, liposarcomas arising. We can have the various neural origin neurogenic tumors. We can have lymph nodes, pathology related to the lymph nodes, lymphoma, METs, tear Cox. We can have lymphangiomas, cystic hygromas, and we can also have the third branchial cleft cyst in this posterior cervical space. So looking at the one pathologies of this in this space, so this is a axial T1 and T1 fat sat MR image. So we can see, so this on the right side normal, this is the normal uninvolved posterior cervical space on the right, and on the left we can see a T1 hyperintense lesion which is seen involving the posterior cervical space, and the corresponding T1 fat sat image, you can see that you can see the suppression of the fat in this lesion, and so this is a case of lipoma which is seen in the posterior cervical space. Another pathology in this posterior cervical space, the axial CT and coronal MR images. So in the axial CT images, we can see multiloculated fluid signal intensity, fluid attenuating lesion involving the posterior cervical space. And on there's a coronal MR T1 post contrast on the right side, and T2 fat sat image on the left. We can see this multiloculated hyperintense lesion this is the lesion, and on the corresponding contrast images, it is not showing any significant contrast enhancement. So so a fluid signal lesion in the posterior cervical space, very common lesion in this space, the lymphatic malformations you can have in this space commonly. So this is a case of lymphatic malformation in the posterior cervical space. So that was about the pushes of all the four spaces which we saw spanning across both the supra and the infrahead neck. Now we just move on to the last space in the infrahead neck, the visceral space. It's only in the in the infrahead portion, doesn't extend in the suprahead portion. That's the visceral space located centrally, comprising of all the comprising of the thyroid, parathyroid, larynx, esophagus, trachea, all the central compartment lymph nodes. They're all included in this visceral space. Very important mention about while dealing with visceral space pathologies, we always need to extend our scan like while imaging till the carina, because all these structures located in this visceral space drain in the superior mediastinal lymph nodes. Hence, it's always important to uh, extend the scan inferiorly to look for any involvement inferiorly. So, just looking at this any visceral space pathologies, on the X-ray we can see this soft tissue fullness in the upper mediastinal region. It's seen displacing the trachea towards the right side. And on further evaluation, a CT was done, and there was a bulky thyroid with multiple nodules within. So this was a case of multinodular thyroid showing intrathoracic extension, one of the pathologies of the visceral space. Another pathology related to the visceral space, we can see this fluid attenuating lesion in the larynx. You can see it's extending internally as well as externally, and this is a typical laryngocele, and in this case it was a laryngocele, it was secondary laryngocele as a result of this primary mass lesion. There was a resultant secondary laryngocele in this case. Another pathology related to the visceral space. So so that was about the visceral space, and just a quick mention about the few other spaces. Coming anteriorly, we have the sublingual and the submandibular spaces, and we have the mylohyoid muscle which separates these two spaces. We have the sublingual space superomedial to the mylohyoid, and the submandibular space inferior to the mylohyoid. And contents wise, sublingual space contains or comprises of the sublingual glands, the ducts, the muscles, nerves, and fat. And in the submandibular space, we have the submandibular gland, predominantly the superficial component of the submandibular gland. The deep part of the submandibular gland is a part of the sublingual space. Then we have the anterior bellies of digastric. In addition, we have nodes and vessels in the submandibular space. Just to review the anatomy related to these to the submandibular and sublingual space. So we have the illustration and with actual T1 weighted MR image. So that's the midline lingual septum. Lateral to it, we have the genioglossus. That's a mylohyoid muscle in this arrow. That's mylohyoid. And we have the medially, superomedially, that's the sublingual gland. And laterally and inferiorly, we'll have this is the submandibular gland. Corresponding MR images, the midline rapid, genioglossus on the either side. And that's the region of sublingual gland out here. And these are the areas of the regions of submandibular. Another diagram with MR image and the coronal plane. That's these are the genioglossus. Then these are the geniohyoid muscle, and that U-shaped sling, that's our mylohyoid muscle. And so inferiorly, that's the region of that's the area of submandibular gland. And superiorly, here we will be having the sublingual gland. And these are anterior bellies of digastric in the floor of the mouth. So corresponding uh, corresponding coronal detuated MR image. So that's the that's the mylohyoid sling. The anterior bellies of digastric on either side. The genioglossus. And genioglossus and the geniohyoid. And just the various pathologies in these sublingual and submandibular space, we can have granulas, hygromas, abscess formations, sialadenitis, lymph nodes, dermoid epidermoid cysts, and second branchial cysts. Just CT, just axial and sagittal CT images. We can see this cystic lesion, which is seen in the these are the genioglossus. And laterally, in the sublingual space, we have this cystic lesion, and which is also seen extending inferiorly into the submandibular space. So these are the submandibular glands, and you can see the cystic lesion extending inferiorly into the submandibular space as well. This corresponding sagittal image to note the extent of the lesion. And common cystic lesions in these cases are very common. This is a case of ranula, and simple ranula is mainly confined in the sublingual space, and plunging or diving ranula is the one which extends and involves both the sublingual and the submandibular space. So this is a case of a plunging ranula. Lastly, just so in addition to what the spaces we have seen, we can have some pathologies which are located in involving multiple spaces, like lymphadenopathy, which we can see, which may be seen involving multiple spaces at a time. So, yeah. So to conclude the talk, understanding the facial spaces of the neck is crucial to the understanding of the various neck pathologies. We always need to look for any asymmetry after aligning our scans properly, and need to compare the normal with the abnormal side to look for any asymmetry. Need to identify the space which is involved, the epicenter of the lesion, which is involved by the pathological process, because based on that the contents of that space, that will help us to generate anatomical based differentials, which we can further narrow down based on additional imaging pattern and relevant clinical information that can help us uh, towards the diagnosis. Thank you.